Hi, I'm Kristen Azar, a nurse researcher and the scientific medical director of the Sutter Health Institute for Advancing Health Equity. Our team of scientists, clinician researchers, and analysts use the resources and data within Sutter's integrated network to incubate innovations and solutions to eliminate health disparities within our system and beyond.
I'm Stephen Lockhart, former Chief Medical Officer of Sutter Health and the founding director of the Sutter Health Institute for Advancing Health Equity. I'm a statistician and board-certified anesthesiologist, and in my newly found spare time, I solve complex mathematical equations.
I'm Alice Pressman, Executive Director and Senior Investigator for the Sutter Health Center for Health Systems Research and Research Director of the Sutter Health Institute for Advancing Health Equity. I'm an epidemiologist and a biostatistician, and today we are going to introduce you to our newly developed COVID-19 Vaccine Equity Index.
With the pandemic caused by the virus SARS-CoV-2, the world is facing the greatest public health crisis since the Spanish flu in 1918. To date, more than 500,000 people have died in the United States alone. However, the burden of severe illness, hospitalizations, and death has been disproportionately borne by communities of color, exposing the gross inequities in our society and in our healthcare system. The arrival of effective vaccines, developed in record time, has provided hope on the horizon. This is a photograph of Ms. Edna Brown receiving a vaccine. An African-American woman aged 107, she has survived other public health crises, the Spanish flu, measles, mumps, polio, and now, thanks to the vaccine, will survive COVID-19. Her son, Mr. Lonnie Brown, also vaccinated, reflected on the impact and importance of vaccines, especially in communities of color.
My friends, associates, there is that myth out there that they want to wait and see what happened. They don't want to take it at this point because the vaccine was made too quickly. They don't want to take it because of the experiments that the Tuskegee people did years ago. And I just like to try to debunk some of them from the standpoint that I know that a lot of research went into this. It wasn't just made overnight. This research has been going on for years. And so at this point, I just see the fact that we are blessed to have these vaccines at this time. And these are life-saving, measures. And I think more black people need to get on board in terms of getting the vaccine taken rather than, shying away from it. And because you can wait too long, it might be too late. I recommend that everyone should get vaccinated as soon as possible because the more people we can get vaccinated, the sooner we can get back to our regular lives. I feel great that, we can once again try to return to some kind of family gatherings again that we have not had since COVID hit. We haven't been able to share Thanksgiving. We normally celebrate my mom's birthday every year. We did that on Zoom. We did our Christmas celebration. We had to do it on Zoom. So it would be nice to be able to get our family members back together again.
Getting back to our normal lives is something we all want. Reaching herd immunity through mass vaccination holds that promise. But as we vaccinate, can we also use this opportunity to simultaneously address the racial and ethnic disparities in outcomes resulting from this disease? As the scientific medical director of the Sutter Health Institute for Advancing Health Equity, it has been my privilege to lead a team dedicated not only to identifying and quantifying disparities, but also to seeking solutions that promote equitable outcomes. In this presentation, we will share the COVID-19 Vaccine Equity Index, a novel metric intended to aid in the development of vaccination strategies that advance equity among various racial and ethnic groups, protecting the most vulnerable while moving us closer to herd immunity, thereby protecting us all.
3 COVID vaccines manufactured by Pfizer, Moderna, and Johnson & Johnson are currently approved for use in the United States. All 3 are incredibly effective at protecting against transmission of the virus, preventing infection more than 90% of the time. In the rare event that a vaccinated individual does become infected, the likelihood of severe illness, hospitalization, or death is virtually zero. These benefits accrue to individuals who are vaccinated, but additional benefit is conferred on the population as a whole when herd immunity is reached. Herd immunity is a form of indirect protection from the virus that can occur when a sufficient percentage of a population has become immune to an infection, whether through vaccination or previous infections, thereby reducing the likelihood of infection for individuals who lack immunity. Although our understanding of COVID-19 is continually evolving, a reasonable estimate would require that 70% of the population be vaccinated to achieve herd immunity for this virus.
As we roll out our mass vaccination strategy, how do we track and monitor our progress? An index can be used to identify and quantify disparities in outcomes for COVID-19 among subgroups of the population. Previously, we created a Health Equity Index, which we named the HEI, for ambulatory care sensitive conditions, providing us with the ability to improve care for our patients with diabetes and asthma. Now we have created a COVID-19 Vaccine Equity Index, which we will refer to as the CVEI, to guide us in our efforts to roll out the vaccine equitably. We will provide an example of the use of the index by applying it to racial and ethnic subgroups. In the case of the vaccine rollout, an index points to the opportunities for targeted outreach. It allows us to monitor our efforts, and it helps us to benchmark our progress towards accomplishing our goal of herd immunity while achieving more equitable outcomes for all we serve.
As we proceed to develop the COVID-19 Vaccine Equity Index, or the CVEI, it will be important for us to define and contrast the concepts of equality and equity. Let's start with the concept of equality. Equality reflects the degree to which the actions we take apply equally to everyone. For example, in this graphic, we offer a bicycle to each of 4 individuals. Equality would be achieved by treating each person the same. That is, by giving each of them an identical bicycle. Of course, the consequences of taking that action is that for one, the bicycle is too large, for another, it is too small, and for another, due to limitations in mobility, the bicycle cannot be used at all. Equality is a measure of the actions we take. It does not provide an assessment of the impact of our actions.
We now want to take the concept of equality, meaning that we offer the same treatment to everyone, and show how to express this concept mathematically. Let's assume that within our population we identify 4 racial and ethnic subgroups: African American, Asian, Hispanic, and non-Hispanic white. If we intend to vaccinate 70% of our total population, a goal consistent with achieving herd immunity for COVID-19, we must offer vaccinations in equal proportions to each subgroup. That means the identical rate of 70% for each subgroup. This is equality. In further discussions about the index, instead of concentrating on the proportion vaccinated, it will be useful to think of the complement, namely the proportion who are unvaccinated. It is the unvaccinated group who remains unprotected from COVID. We denote unvaccinated by the letter U. In this case, that proportion would be 30% for African American, as well as for Asian, Hispanic, and non-Hispanic white. As expressed by the equation on the slide, the unvaccinated percentages for each subgroup are equal and the same as the unvaccinated percentage for the total population. Another way of stating this is to examine the ratio P of U of S divided by P of U of T, which is the probability of being unvaccinated for a subgroup divided by the probability of being unvaccinated for the total. Equality occurs when that ratio is 1 for all subgroups. Please take note of this ratio, as it will take broader significance as we derive the COVID-19 Vaccine Equity Index.
Let's now contrast the concept of equality with equity. Unlike equality, equity is achieved when all parties experience the same outcomes. Of course, this means that we may have to treat various groups differently in order for each to achieve the same desired outcome. Equity requires that our actions be tailored to meet the specific needs of the various groups we serve. Equality is about what we do, whereas equity is about the impact on those we serve. In our bicycle example, if we are to achieve equity, we would offer a bicycle of the appropriate size for those who are able to ride an upright cycle, and offer a recumbent cycle to the person with limited mobility. The desired outcome is that each one of them can now ride away on a bicycle. In the context of COVID-19, Equity means that for every person, we are able to offer the best outcomes regardless of their race or ethnicity.
Within the context of COVID-19, our challenge is to take the concept of equity and translate it into a mathematical construct that provides tools and insights for advancing equitable solutions. The COVID-19 Vaccine Equity Index is a novel metric. It is designed to identify disparities in outcomes among various racial and ethnic groups and highlight strategies for vaccination that will directly address disparities while simultaneously moving toward the desired goal of herd immunity through mass vaccination. Using straightforward mathematical principles, we will show you, step by step, how the index is derived. The derivation process provides a deep understanding of what we can learn from the index and how it can be used to develop a vaccination strategy. By creating an index, we are taking the concept of equity, which is about outcomes, and translating it into a quantitative or mathematical construct. But how do we define a bad outcome within the context of COVID-19? Here is our idea. We define a bad outcome as occurring for someone who is unvaccinated, which we denote by the letter U, and this individual is also infected, which we denote by the letter I, and is subsequently hospitalized, which we denote by the letter H. Now, the combination of being unvaccinated and infected and hospitalized is what we define as a bad outcome. And the probability of a bad outcome is what we want to compare for each subgroup. In this case, our subgroups of race and ethnicity are African American, Hispanic, Asian, and non-Hispanic white. For each of these subgroups, we wish to compare the probability of a bad outcome to the probability of a bad outcome for the total population. We define the COVID-19 Vaccine Equity Index as simply the ratio of those probabilities. The probability of bad outcomes for a given subgroup in the numerator compared with the probability of bad outcomes for the entire population in the denominator. The core of the index is its ability to compare outcomes. It compares outcomes for each group, in this case defined by race and ethnicity, with outcomes experienced by the population as a whole. When the likelihood of a bad outcome for a particular group, the numerator of the index, is the same as for the general population, which is the denominator of the index, there is equity, and the CVEI equals 1. When bad outcomes are more likely for a given group compared with everyone else, the numerator of the CVEI increases, and the index is greater than 1, signifying disparity in outcomes. The magnitude of the index directly reflects the degree of disparity. Of course, there may be instances in which a group has outcomes better than everyone else, in which case the index will be less than 1. While it may be instructive to understand the origin of these better than average outcomes, our focus is on using vaccination as a potential remedy to assist those suffering disparities. Now that we have defined the index, we need to have an easy way to calculate and interpret it. To accomplish this next step, we need to engage in a small explanation of conditional probability. The best way to do this is with a fun and illustrative example. When we return, we will have the tools we need to complete the derivation and fully understand the index and its surprising interpretation. One of the most well-known examples of conditional probability comes from the TV show Let's Make a Deal, hosted by Monty Hall. The objective of this show is to win a car which is placed behind one of 3 doors. Behind the other 2 are goats. So let's suppose you are a contestant on the show. Here is door number 1, door number 2, and door number 3. You, the contestant, select door number 1. Now, the probability that the car is behind door number 1 is 1 out of 3. The same is true for door number 2 and door number 3. Stated a little bit differently, the probability that you are correct in your choice of door number 1 is 1 out of 3, and the probability that you are wrong is 2 out of 3. Namely, the car could be behind door number 2 or door number 3. Now Monty comes along and changes everything. He says, I will show you what is behind door number 2. Do you want to change and pick door number 3? Let's make a deal. What to do? Well, the probability that you correctly chose door number 1 is still 1/3, and the probability that you were wrong is still 2/3. Then Monty changes everything by showing you that behind door number 2 is a goat. But still, the probability of being wrong is 2/3. But now we know the car is not behind door number 2, so being wrong about door number 1 is equivalent to the car being behind door number 3. So the probability that the car is behind door number 3 is 2/3. This becomes twice as likely as door number 1, and you should switch. So what just happened? Before you had this information, the probability that the car was behind each of the doors, namely that it was behind door number 3, was 1 out of 3. But then Monty changed everything by giving you some information. Namely, you picked door number 1, and he told you the goat was behind door number 2. With that additional information, the probability that the car is behind door number 3 went up to 2/3. The probability of the car being behind door number 3, given that you picked door number 1 and the goat was behind door number 2, increased. This is conditional probability. Conditional probability is governed by something called Bayes' theorem, which states that the probability that two events, A and B, occur together is the probability that B occurs times the probability that A occurs given that the event B has already occurred. And given is denoted by the vertical line indicated by the arrow. We will see that this theorem is central to how we develop the index. Let's take a closer look at Bayes' theorem and compare it with a probability that we used in the index, the probability of a bad outcome. With the exception that the version of Bayes' theorem we used contemplates two events, A and B, the expression probability of being unvaccinated, infected, and hospitalized can be written as P of U, I, H is equal to the probability of being unvaccinated times the probability of being infected given that you were unvaccinated times the probability of being hospitalized given that you were infected and unvaccinated. This is just an extension of Bayes' theorem for three outcomes. How does this help us? Remembering that the CVEI is the ratio that compares this expression, the probability of a bad outcome for a subgroup, to the total population, we are left with the following surprising observation. The CVEI can be written as the product of three ratios. R1, which reflects the actions we take to vaccinate a given group. R2, which reflects infection rates for the group compared with everyone else. And R3, which reflects the relative likelihood of group members who are infected to become severely ill and be hospitalized. R2 and R3 are unaffected by the actions we take with vaccination, but quantify potential disparities experienced by the group associated with either disproportionate infection rates or hospitalization rates. However, we can mitigate the impact of elevations in these ratios, which mark the presence of disparities, by increasing the amount of vaccination within the group. These actions we take to increase vaccinations will affect R1. Recall that increases in vaccination decrease the unvaccinated population and leads to decreases in R1, which will drive the CVEI down closer to 1, which represents equity. In this way, we can use vaccination as a tool to address disparities reflected in R2 and R3. Also, information about R2 and R3 help inform efforts to target vaccinations at those at highest risks for either infection or hospitalization. We demonstrate how this works in an upcoming example. Finally, an interesting observation. In the event that there are no disparities in infection rates, and this means that R2 would equal 1, and there are no disparities in hospitalization rates, meaning that R3 equals 1, then the CVEI reduces to the ratio R1, which we saw is simply a measure of equality. So if there are no disparities, and only in the absence of disparities, equity can be achieved by treating everyone equally. However, if there are disparate outcomes among groups, we must use differential vaccination strategies for each group if we hope to achieve equity.
I'd like to share an example of how we use the index to identify inequities and inform our outreach so that we can deploy vaccine in a way that will not only achieve herd immunity, but will also achieve equity of outcomes. Because there are many underlying factors that determine the likelihood of infection and hospitalization, we use techniques like logistic regression to calculate R2 and R3, adjusting for multiple factors. I won't go into the details, but that happened behind the scenes in this example. Given what we know about the spread of COVID-19, setting a goal to vaccinate 70% of the population is a reasonable estimate of what is required to reach herd immunity. Let's suppose that our population is comprised of 4 major subgroups defined by race and ethnicity: African American, Asian, Hispanic, and non-Hispanic white. A vaccination strategy based on equality would lead us to vaccinate each of these subgroups in the same proportion, or 70%. But if our goal is to afford members of each subgroup access to the same outcomes, we need to develop a vaccination strategy based on equity. Based on data from our healthcare system, we calculated a CVEI of 2.0 for our African American patients. This means that the probability of a bad outcome for our African American patients is twice the probability of a bad outcome for our total population. We can change R1, which reflects how we choose to administer the vaccine. In fact, by increasing the proportion vaccinated to 81% and thereby reducing R1, we can reduce the CVEI to 1.0 and achieve equity. Using electronic health record data, we use logistic regression to calculate R2 and R3. A closer look reveals that our CVEI of 2.0 was driven by an average R2, but a very high R3. We can use this information to inform our outreach. In this case, with a high R3, we will target those African American patients at highest risk of hospitalization if they are infected, such as those with underlying health conditions. Our Asian patients had a CVEI of 1.1. This is very close to equity, and in fact, simply adjusting our goal for Asian patients just slightly to 71% allows them to experience equitable outcomes. For our Asian patients, an R2 of 0.8 indicates a lower risk for infection, and an R3 of 1.1 indicates a slightly higher risk of hospitalization. Our Hispanic patients had a very high CVEI. It was 2.84, the highest among the 4 subgroups. In this case, in order to achieve equity, we must increase our vaccination goal to 88% for our Hispanic patients. Unlike our African American patients, our Hispanic patients are at very high risk for infection. This is reflected in an R2 of 2.2. On the other hand, they are at only slightly increased risk for hospitalization with an R3 of 1.2. So we want to focus our outreach on vaccinating those who have increased exposure through frequent interactions with others. Examples may include essential workers and those living in multi-generational households or congregate living environments. Our non-Hispanic white patients have lower probability of bad outcome than the total population, reflected in a CVEI of 0.66, more favorable than what is required for equity. This is why the target vaccination percentage to achieve equity is only 57%. For our non-Hispanic white patients, both infection rates measured by R2 and hospitalization rates measured by R3 are less than 1, representing below average risk for both. A vaccination strategy based on equality means equal treatment, whereas equity means equal outcomes. The CVEI is a framework that can be used by healthcare systems, public health departments, and other entities that want to create equitable vaccine rollout strategies. Using available electronic health data, R2, infection, and R3, hospitalization, can be derived for any subgroup of a population. Although others have created metrics to evaluate vaccination programs based on equality, we believe that the COVID-19 Vaccine Equity Index, which is based on advancing equity and improving outcomes, is a more productive approach. The CVEI provides both a way to identify targets for outreach and a way to track equity as we strive for herd immunity.
We hope you have enjoyed learning about the COVID-19 Vaccine Equity Index as much as we have enjoyed the opportunity to share it with you. We believe that the CVEI is a useful tool that can be used by health systems, county or state health departments, or any entity involved in vaccination efforts. There is an opportunity for us to use the vaccine not only as a tool to reach herd immunity, but also as a tool to address outcome disparities. We are happy to answer further questions and share more detailed information about how to deploy the index. If you are interested, please contact us at the email address below. At Sutter Health Institute for Advancing Health Equity, we believe that solutions that promote and increase equity benefit everyone. That is why our team of clinicians, researchers, educators, and operators is dedicated to developing and sharing solutions, as well as collaborating with and learning from others. If you would like to learn more about the Institute, please visit our website listed below. Thank you so much for joining us.